Built from the ground up, specifically for small animals, Hallmark offers an MRI solution that provides the highest quality diagnostic imaging with a practical business model and unrivaled support. With over 2 decades of experience and over 120,000 patient images, Hallmark is committed to providing access to state-of-the-art resources to clinics and practices around the world. Building on their unrivaled success in the equine market, Hallmark's 1.5T small animal MRI system has kept the patient and you at the forefront of every design decision. Your patients range from small to large, with anatomy that requires dedicated hardware and software to optimize image quality. With 16 channels to help you see more and scan faster, a V-shaped patient bed, veterinary-specific MRI coils, and a unique panoramic glass hatch, this self-shielded system delivers the specialized technology your practice demands. A sliding roller system allows for fast patient access in and out of the bore, which minimizes the time the animal is under general anesthesia. Optimum patient positioning is ensured with coils that feature an open-top design and a phased array system that enables the use of 2 coils simultaneously, allowing you to better image hard-to-reach anatomy. The panoramic glass hatch allows free access to your MRI room during scanning, and a dedicated video monitoring system further enhances patient safety. The advanced cooling system is designed to save you precious time and money. This includes a zero boil-off cold head that constantly recycles helium and eliminates the need for helium top-offs. The air-cooled compressor maintains constant helium levels at all times, even if the chiller defaults. Hallmark's world-class Q-Care service and support program confirms their commitment and encompasses all that they do as a team to support your business success. This includes the Hallmark 99% uptime guarantee, ensuring the care your clients need is available when they need it most. Innovation that works for you. Don't wait to take advantage of the latest technology. Partner with one of the most experienced animal MRI companies in the world. We speak vet at hallmark.net.
Welcome everybody. We are back for our summer series. Proud to be here, supported by Hallmark Advanced Veterinary Imaging today, and introducing you to Ronaldo da Costa, Dr. Ronaldo da Costa. I'll do introductions in a second, but we're very excited to get going on his talk on cervical spondylomyelopathy today. No introductions needed, though, for Dr. Laurent Grossi, who is on the top of his rooftop suite, looking over Manhattan or someplace in Norfolk, England. We are going to put him on mute because I think he may have had some afternoon drinks. We don't know. But great to be back and getting us going. Obviously, we've got people coming in from all over the world here, at least 5 right now. And so we're going to get us going. Now, I'm not going to make any excuses for reading this, Ronaldo, but I am going to read your bio because I don't want to miss anything. And there's quite a lot on there, right? Because you're very accomplished, so don't want to miss anything out. Now, most people will know Dr. Ronaldo da Costa here, full professor, currently service head of neurology and neurosurgery at the Ohio State University. He's co-editor of the Practical Guide to Canine and Feline Neurology and guest editor of Veterinary Clinics on Spinal Diseases, published in 2010. He's also continuing the consulting editor on neurology section for the 8th edition of Ettinger and Feldman's and the 16th edition of Bonagora's Kirk's Current Veterinary Therapy. Ronaldo is the founding and current president of the Brazilian Veterinary Neurology Association and has served in numerous committees in the US and internationally. He's an active clinical and research program, or he has an active clinical and research program on spinal diseases, and has published over 110 scientific articles and book chapters, including 45 on cervical spondylomyelopathy. Dr. da Costa has also received over 30 awards for research, teaching, and academic excellence, including 7 teaching awards at The Ohio State University. such as the Pfizer Norden Teaching Excellence Award, which is the highest college teaching award available, and the Excellence in Graduate Education Award in 2013 and 2016. He was a finalist in the selection for the National Pfizer Norden Award, which was the highest teacher honor in the USA in 2012. Wow, excellent. How do you have any time left for this? Incredible, but thank you very much for giving up your time. We know that you just come back from Brazil, so hopefully you are all rested, but maybe not. We today are going to look to your knowledge on cervical spondylomyelopathy, and we all know that you've studied this now for decades. So we can get started if you're good. Again, want to thank Hallmark Advanced Veterinary Imaging for sponsoring this, and Dr. Costa for giving his time. Are you able to share your screen then, and we could get started?
Share screen. Sure.
There we go.
Great. All right, great. Thank you very much. We've got us started now. So I can ask a few questions to punctuate this. And I guess the first question that everyone would like us to start off with is what exactly is cervical spondylomyelopathy?
I will answer that, Simon, and many others. But first, I would like to thank you and Laurent for the invitation and for having me. All the questions you asked me about how can I, do I have time for this? I mean, I could ask you both the same. So, but I really, really appreciate the opportunity. I also appreciate everyone's time. So good morning, good afternoon, good evening, depending on which part of the world you are now or when you're watching this. So we certainly very much appreciate your time and your willingness to either join us or watch this afterwards. So let's talk a little bit about cervical spondylomyelopathy and focus on kind of some general terms and a little bit of pathogenesis, some on diagnosis, and I'll kind of leave treatment out because that's quite complex. So we just focus primarily kind of some basis for the diagnosis of the disease. But before that, I think it's very important that we define the problem, right? And there's not a hell lot of diseases that have received 15 names over the years to define the same disease process. And I mean, clearly there is a reason for that, right? The reason behind is that we're still trying to understand this disease. I think we know much more about it than what we knew maybe like 2 decades ago, but it's definitely a work in progress. There's too many questions that we have to answer. And in general terms, I can say that's probably the most common disease of the cervical spine of large and giant breed dogs. It does happen in small breed dogs and medium-sized dogs, but it's a lot less frequent. It's generally characterized by spinal cord and nerve root compressions, and you can see that the prevalence here is kind of affects basically between Dobermans and Great Danes, which are the 2 most commonly affected breeds, kind of 1 out of 20 of those dogs, those 2 breeds specifically. And whether you're going to see more Dobermans or Great Danes, it really depends on where you practice. Like in Canada, where I did my residency and PhD, we used to see like lots and lots of Dobermans by far. Like that's why my PhD was on Dobermans. Here in Ohio, we see probably 3 times more Great Danes than we see Dobermans. So it really I'm just about 6 hours from like Guelph, where I was a few years ago, so 2 decades ago actually. So it really depending on where you are, you will really see very different populations affected by this disease. And I have here like some of the names that were coined over the years, but I really for simplicity, and I actually have a great idea for another name, but I don't think the disease needs 16 different names. Okay, so I do want to kind of define the 2 general groups of cervical spondylomyelopathy, because they're kind of quite different. And even though I'm going to define those, I also want to tell you that there is an overlap, and this is really with data that we'll publish either this year or later next year. There's an overlap in about 25% of dogs. So in 75% of dogs, we can divide the disease into disc-associated CSM and osseous-associated CSM. Disc-associated CSM we'll see primarily in large breed dogs. There's a very clear disc component of it. I'll show you a better illustration of this. We tend to see in older dogs, whereas osseous-associated CSM we see primarily in giant breed dogs, younger dogs. A lot of them would be 1, 2, 3 years. I would say, the average is 2.5 years, but in a prospective study that we did here at Ohio State, we learned primarily in Great Danes, we learned that the dogs had an average duration of clinical science of 1.9 years. So it's a very slowly progressive condition, which might be more or less easy for people to pick up on the gait features of the disease. And that's why I think that the disease progresses for such a long time. Okay, disc-associated CSM, which is the classic form that we'll focus here, and the classic form that we see in large breed dogs. What do you see? We see a ventral compression, oftentimes like in association with some degree of dorsal component, either at that site or different sites. And when we look at the transverse view, what we can appreciate is that, so this is a normal plate showing the normal relationship between the spinal cord, nerve roots, like disc and everything. Here we see a midline compression with ventral and dorsal components. We can also see this an asymmetric spinal cord compression, which many of those cases we'll see foraminal stenosis, and that's where we can see more spinal pain. Spinal pain, generally speaking, is not a big feature of cervical spondylomyelopathy. And then we have the osseous-associated form of the disease. That, again, giant breed dogs, younger dogs, 2 to 3 years old, a lot of them at the time of diagnosis. What do we see? We don't see a ventral compression. We see a lateral compression, a kind of dorsolateral compression, or a purely dorsal compression. And usually here, this disease is a little more complex from both a diagnostic and treatment perspective, because about 80% of these dogs have multi-level compression, as opposed to about 50% of disc-associated CSM. So just basically the top part of the vertebrae is affected. And as I said, in about 25% of dogs, we see the combination of both disc and osseous-associated CSM. Okay. I do want to show you this because I think it's important that you all can appreciate the gait of dogs with CSM. So first, I want to show you and these are very classic and very severely affected dogs. There's a marked range of signs that are, I would say, moderate to mild compared to that dog. But this is Dana, or was Dana, a 7-year-old Great Dane that came to see us with a very chronic history. Her history would go kind of anywhere between 4 to even 5 years of duration of clinical signs. So you can see how she has a very clear proprioceptive ataxia in the pelvic limbs. But in her case, the thoracic limbs are very obviously affected, very severely affected. And you see when she turns, how she's very weak, she's crossing, she's very paretic in the thoracic limbs. Many dogs have generally speaking, the signs are much milder early in the disease process. And in the bottom of the screen now, I have a Doberman that's also, I would say, has kind of a severe presentation. And this dog had a 3-site compression. And you can see in the Doberman, we see more like the classic gait that we see, I would say, in the majority of dogs. That's kind of the 2-engine gait, the short stride gait in the thoracic limbs, and the long stride gait in the pelvic limbs. Always with proprioceptive ataxia in the pelvic limbs. The degree of proprioceptive ataxia in the thoracic limbs is quite variable. Many times we see very mild ataxia, mild paresis, and that short strided gait, which really clearly reflects the location of the lesion. No matter what, in both disc and osseous-associated CSM, we're talking about a caudal cervical myelopathy. C5, C6 compressions and C6, C7 compressions of all directions. The clinical signs are basically the same, okay? All right, let's move on then. Now, I mentioned to you that I did my PhD at Guelph at the Ontario Veterinary College. That started about 20 years ago. And contrary to what people think, I've heard that people, when introduced me, Simon didn't say that, oh, he loves cervical spondylomyelopathy. I actually don't. I used to hate it. And I was basically forced to study this in my PhD because the other two projects failed miserably. And I had no choice other than going to this. But when again, like that's 20 years ago, when you look at the papers, most of the papers were about surgery, and it was a disaster. And the diagnosis, it was all over the place. And I said, okay, if I have to study this damn disease, I want to start by studying what would be normal. And so I kind of said, but let me look at everything that's published that's showing like the MRI features of the disease. We focus on MRI a lot. It was MRI based, the project, with other stuff like electrodiagnostics, myelography, and other things. But so I remember finding this in a book chapter, and it was a Doberman, kind of middle-aged Doberman, with this mild spinal cord compression and this disc degeneration. It was a working dog, and they said the dog had done a lot of biting work and stuff, and that led to this disc degeneration, this mild ventral spinal cord compression. So I said, okay, well then, sounds good, right? And we started, like, the goal was to recruit 16 normal Dobermans and 16 Dobermans with CSM, disc-associated CSM, to compare all the like morphologic and morphometric features of the disease, to try to understand a little bit what actually was happening with those dogs with the disease, cervical spondylomyelopathy. And I have here 4 MRIs that I want to share with you. So for those of you who are not familiar with MRI, all images will show you this side of the screen here. It'll be always cranial, always dorsal, always ventral here, and always caudal. And in this set of images, I have C7 labeled in all of them. This grayish tubular structure in the center is the spinal cord. This kind of tic-tac shaped structures are the intervertebral discs. And so we go basically from C2, 3, all the way down to C71. And you can see here, beautiful intervertebral discs, no evidence of spinal cord compression, maybe a little bit of subarachnoid space compression there. Now we have another one with severe spinal cord, disc degeneration here, spinal cord compression ventrally, a couple of other bumps there. Like this other one, same thing, complete disc degeneration, ventral spinal cord compression. And then this last one, that basically all discs are degenerated except this one, that's C3-4, that's partially degenerated. And then we have multiple levels of spinal cord compression and even dorsal spinal cord compression. The problem is, which is something I was quite shocked when I learned, these MRIs, all of these 4 MRIs are from clinically normal Dobermans. So we actually learned that 25% of normal Dobermans have spinal cord compression, 100% of normal Dobermans have some degree of disc protrusion, and 75% of them have disc degeneration. So that was kind of quite shocking. And we published this back in 2006, like 15 years ago. Very heavy paper. I should have probably divided that because we had all the morphologic stuff there and all the morphometric stuff. When your own advisor tells you that it's kind of a little much, it's probably a little much. So with that, I will kind of give a break now and see if.
Yeah, that's a great way to start. Thank you, Ronaldo. I guess leading on from there, the big question is how do you really differentiate a standard disc protrusion in the caudal cervical spine from cervical spondylomyelopathy? And just before you get started, your laser pointer on mouse wasn't showing up. I'm not sure if you can change.
Is it?
Yeah, I can see it now. There you go.
Okay. So I have to keep. The problem is that every time I change the slide, this red laser disappears. So I will it will take me a second more, but I kind of do that. So hopefully, no, it stayed actually. So great question, and I don't know if I have the whole answer for that, but what I can tell you is that, interestingly, when I told you that in this study here, we looked at all the morphology and the morphometry. One thing that we also did, we basically measure like the vertebral canal from C2, 3, all the way to C71, okay? And why did we do that? Because we really, we did 120 measurements to try to understand this disease in the cervical spine of each single dog. And what we can see here is that, like basically the yellow bars are the clinically normal dogs, and the blue ones, the CSM affected Dobermans. And as we can appreciate, even though the disease tends to really happen kind of 5, 6, 6, 7, so they call the cervical spine, we see that even from C2 down to C71, the vertebral canal of these dogs is smaller. Like, so they have what we should call relative vertebral canal stenosis. That's different from absolute vertebral canal stenosis, the type of stenosis that we tend to see in the osseous-associated CSM. That's the actual vertebral canal stenosis causes spinal cord compression. This doesn't, but it actually reduces the threshold for spinal cord compression. So whereas Dobermans, like any Doberman can have spinal cord compression, only those with a smaller vertebral canal would be prone to actually develop clinical signs secondary to disc-associated CSM. So from a static perspective, I would say that this relative vertebral canal stenosis is a key point. Not super easy to appreciate that on an MRI, though I don't disagree. Obviously, after looking at hundreds of MRIs of these dogs, I can pick up on that, but not that easy if you are not familiar with MRI of like disc-associated CSM or osseous-associated CSM. Obviously, all these measurements are published, so if anyone would like to, they can refer to the papers. And we've done sort of the same study in Great Dane, so we have both kind of reference standards for both disc and osseous-associated CSM. And when I mentioned that we have a static feature that predisposes dogs to that disease is because another very important point of this disease, disc-associated CSM or CSM in general, is the dynamic component. And dynamic component is very different from instability. There's over the years, and primarily when you go back to the papers back in the 70s, you can see that what people would see as dynamic vertebral canal compression or vertebral canal stenosis, spinal cord compression, people thought that meant instability, which is obviously very easy to understand. We're talking about 40, 50 years ago. Now we kind of know that that's not quite the same. And so we've done some biomechanics studies, we've done some MRI related studies, but you can see here, because one question is why, I showed that vertebral canal stenosis is present throughout the cervical canal. So from C2 to C71. Why are the lesions concentrated in the caudal cervical spine? Well, I didn't know that. So we decided to look at this biomechanics study to try to understand. And so we separated the cranial cervical spine from the caudal cervical spine. And what we could see is that this rotation, the rotation in the caudal cervical spine, again, C6, C7, 5, 6, and 6, 7, is significantly higher than in the cranial cervical spine. And out of all biomechanic forces, all of them, the one that leads, the one that causes the most severe intervertebral disc degeneration would be torsional forces, so axial rotation. That is what would cause, all forces can lead to this degeneration, but that is the number one. So, and that happens primarily in the caudal cervical spine. Okay, let's move on. And so this is kind of like the dynamic factor that was fairly well known in people for many, many years. And it's quite interesting because you see, when with cervical extension, again, all in humans, the vertebral canal decreases, but the spinal cord area increases. So you can see how extension could be really not good for the spinal cord, to put it kindly, whereas the flexion would do the opposite. Well, that's in humans, right? Does it have the same happen in dogs? Well, again, we looked at that, and we basically got a bunch of cadavers and tried to outline the dorsal aspect of the vertebral canal and the ventral aspect of the vertebral canal, and placed them in neutral, flexion, and extension, and looked at the diameter of the vertebral canal without the spinal cord. Here we couldn't really measure the spinal cord. We're just looking at the diameter of the vertebral canal, or the vertebral canal area. And you can see the numbers here. Between neutral and extension, there's a reduction of 16.5%. And if we go here between flexion and extension, that is almost 30%. I mean, that's a lot. That's quite a lot. You know, imagine when the dog is running, every time he lowers his head and extends his head, there's a change of about 30% of the vertebral canal. If you have something compressing the spinal cord, well, that can clearly push that dog over the edge and make it clinically. And sometimes that's why we see some, like it's not unusual that we see those acute on chronic lesions, dogs that seem to be affected for a long time and they just go down acutely. Okay. And I just want to tell you this because I've mentioned instability and stuff. And before people ask me, and they say, well, like you're saying that there's no instability. And I'm not saying that. I'm just saying that dynamic lesions are one thing, instability is another. And no one to this day, like including me, could prove that there is or there isn't instability. What we do know is that there is a dynamic spinal cord compression. When we surgically stabilize the cervical vertebral column, with which, like, it doesn't matter the technique, we just stabilize, we immobilize that, there's no intervertebral movement. We basically eliminate this dynamic component. So this 30% reduction of the vertebral canal won't happen at that site. Okay, so that's one of the key points or key reasons why those like fusion stabilization techniques work, and they really work, is because of this. They eliminate the dynamic component. Obviously, other problems can happen down the road, but at short term, you should really expect improvement because you eliminate a big player here. And to back up a little bit what I'm saying, and there's a lot more to go on this, but just to stay in the main players, this is a very nice review, like state-of-the-art review on degenerative cervical myelopathy, which is the term that they prefer in humans now. They used to call cervical spondylotic myelopathy. But you can see here the factors involved in the pathophysiology of the disease in people. And so we have spondylosis, we have like this congenital stenosis, which I mentioned, which is a big player. You see the dynamic factors, and that's kind of physiologic narrowing of the canal diameter with neck extension. It's kind of what we talked about. There's some very nice studies showing this forces placed on like the center of the spinal cord. We don't have that, but we assumed it would be the same. And you can see here, like in the dynamic or static, there's no mention of instability. They talk about dynamic factors. I have 3 here. Instability, at least in people, doesn't seem to be a big part of the disease either, or like take any part in the disease process. And you can see here there are 5 biomolecular mechanisms, and that's certainly a big part of the disease that, you know, we've documented that some of them do happen in dogs, like this oligodendrocyte and neuronal apoptosis. We do know that does happen, and it could be one of the reasons why these dogs in the long run don't tend to do as well compared to other spinal related disease. You know, we can talk about survival time for like cervical spondylomyelopathy. We don't talk about survival time for disc disease. You know, we don't talk about survival time for lumbosacral disease, but we talk about survival time for this because clearly these dogs don't seem to do so well in the long run, no matter how we treat them. Okay.
Thank you very much for that bit. So obviously imaging is very important to the diagnosis of this disease, and you've recently published a paper on this. And so why don't you tell us about what you found?
Yeah, very happy to. So let's just cover a little bit of diagnosis from basically the very, modality that everyone can use at radiographs all the way to MRI. And so we can use all of this. You obviously can't really diagnose CSM based on survey radiographs. There's kind of like we publish ratios, and there are some ratios for actually osseous-associated CSM that can be used, but the reality is most people don't like to use rulers and kind of measure things. But if you'd like to, you can. I mean, the goal wasn't really for us to diagnose anything. It was more like a screening tool for genetic studies that we're still doing. But I actually want to show you this because and I will show you like why this is important, even in disc-associated CSM. So it does seem that in a lot of dogs, there are degenerative changes in the articular processes. And these degenerative changes could be more or less obvious. Sometimes they're very obvious. This is actually, here's a German Shepherd, and German Shepherds have I would say, unique type of disease, because I would say that the breed is considered a large breed dog, but they have a lot of osseous component and also ligamentous component. We published on them because we just, here in Ohio, I don't know why, I don't know if you guys, whoever is watching, wherever you guys are watching it from, if you see that, but certainly I see a decent number of German Shepherds with CSM here in Ohio. But I want to point to this. So there's like kind of, if you look at articular processes, the cranial articular process, the caudal articular process, and they should sit nicely on top of each other. They should really sit nicely and allow this kind of nice movement, flexion, extension, lateral bending, and all of this. And there's a radiolucent line that we can expect. So if you look at the radiographs here, we see that. We see the cranial, we see the caudal, we see that there. Now, if we move down here, we can see how these are, like, let's focus on this one that's markedly affected. Look at how this articular process at, so 2, 3, 4, 5, the articular process of 4, 5 is compared with, let's say, this one that's 4, 5. Okay, and this is 6, 7, 5, 6, like 4, 5 here. So you can say, I mean, it does change the anatomy a little bit, but you really shouldn't have all like this osteoarthritic changes, like all this sclerotic, very irregular shape of the articular processes, which we see all over here. So, and we can also see that on the VD radiographs. It's just a lot harder to appreciate, but all of this is the same dog, obviously. But my point is, if you take a well-positioned lateral radiograph and you can look at the disc space. I know everyone likes to really focus on the disc space, but if you look above that and you have this image in your mind, okay, this is how the articular processes should look like. And so this is what you expect here. If you get anything like this, like different angle, like lots of like osteoarthritic changes there, and you can also appreciate how thickened the lamina is, well, that is a radiographic evidence of osseous-associated CSM, okay? So just to give you guys something that you can use in practice easily. But talking specifically about this paper that Simon mentioned, we actually have two, but let's just talk about the disc-associated CSM, a case series. So we did a retrospective study, like of cases that we saw here, all high field, like 3 Tesla MRI. The inclusion criteria was very clear. We wanted to just look at dogs with disc-associated CSM, excluding everything else. Okay, it couldn't be, definitely no osseous-associated CSM. They could have ligamentous component because that's actually part of the disease in many times. If they had osseous proliferation, obviously that wouldn't be. And if they had just ligamentum flavum hypertrophy or foraminal stenosis without evidence of disc protrusion, then they were also excluded. And we want to basically look at the imaging and the clinical findings and see if we could, find any correlations. And here I'm going to show you just a couple of plates from the paper. And this was a Weimar runner with this kind of 2-level compression that you can appreciate. T1 and T2 sequences. I know some places don't do T1s, but I think T1 to appreciate the bony component of this is very, very useful. And you can see the asymmetric compression that I mentioned that is oftentimes associated with more severe cervical pain. And then this is like from a Doberman with a dorsal component here and ventral component. That's kind of, there's one that has this spinal cord signal change, which you can only appreciate on the T2 weighted sequence. We can see on the T1. We can see nicely on the transverse T2. That suggests, in theory, that the site that has spinal cord signal change is the most severely affected site. Okay, so, but you can see there's like one dorsal and one ventral compression. They're not even next to each other. Okay. So what can we say in terms of key findings for this paper? As expected, most dogs were older Dobermans, like 70% of them, with lesions in the caudal cervical region. Interestingly, we also saw this in dogs that were younger than 3. And 8% of cases, so a small percentage considering that we had about 70 dogs, but it's still, we see that. And we also published a paper on juvenile CSM. if you saw me talking about cervical spondylomyelopathy, I would say maybe 4 years ago or even before that, you heard me saying that form of juvenile CSM that was reported in the 70s in dogs that were 3, 4, 6 months old, that was probably a thing from the past. Well, I don't know why it's no longer a thing from the past. It's coming back, and it's coming back strong. And I see it here, but because of, I guess, our work, neurologists from US and Europe, when they get these cases, because they're I would say they're still rare, they reach out to me just to ask for me to confirm, look at MRI, and to say, I mean, is this really Wobblers, like the thing that didn't exist? And it's coming back. So I don't know why. Don't ask me why. I just don't know why, but I can tell you that it's coming back. So we saw more single compressive lesions in younger dogs, so dogs younger than 6. Obviously, older dogs had more, like multi-level compression. Interestingly, so this is kind of the interesting part of this paper. Many dogs had concurrent changes, and so ligamental flavor hypertrophy we saw in basically 38% of dogs, and foraminal stenosis 81%. We did see a weak correlation between the severity of spinal cord compression and neurologic grade, meaning the more severe spinal cord compression, the worse the nerve grade. But we actually couldn't see any association with multi-level compression, so 2 or 3, 4, 5 compressions. Also interesting, that's why I wanted to show you the kind of the radiograph of the articular process, even though we're talking about disc-associated CSM, because 88% of dogs with disc-associated CSM had degenerative changes in the articular processes. So there's definitely more to this than what we can look quickly in terms of just disc-associated CSM when we assess the MRI of these dogs carefully. How everything plays out, or what is the role of each one of these components, we still do not know. Okay. All right.
Fantastic. When still focusing on imaging, what would you say is an important recent development with respect to imaging for cervical spondylomyelopathy? Where are we now with that?
Yeah, no, great question, because I would say that if there's one thing that in the last, I don't know, 5 years, I can say that it's a big development, would be the way we can do MRI for these dogs. And so I mentioned before about the sort of the dynamic component of this disease. All right. But the problem is all the work that I've done with MRI and the way we used to do MRI for these dogs for, I would say, the past 20 years has been in a way that's actually not physiologic. What do I mean by that? We put dogs in dorsal recumbency, so they're laid on their back, and both the thoracic spine and the cervical spine are level, which is not how dogs walk, how they're just look at us. There's always an angle between the thoracic and the cervical spine. I mean, always. If we see a dog with the head down, we know that that's an abnormal neck posture, and it would suggest neck pain. But if we see that, we know that that's abnormal. Okay? We expect them to look at us like this and to move with their head held up. Okay, so when we imaged these dogs and we made all plans based on this, well, we're actually not getting the full picture of what this dog is doing with his cervical spine. Obviously, primarily the caudal cervical spine when he has his head up. So we tried, and thankfully we succeeded. I basically met up with the bioengineering group here, and people are some groups here at Ohio State are wonderful to work with, and I basically just met with an engineer and said, okay, I need you to help me prepare a board, and this is my idea. And I basically drew on a piece of paper, said, but I want you this to look very nice. Ideally, I want you to help me to kind of change the increments in about 10%. I'd say, I don't know, matter of few weeks, he got me this. Okay. And and this here, by the way, we name it the Wobblinator. And this is kind of what we do with the Wobblinator. First, and there are some challenges associated with this, because we can't really image dogs in the oblinator and dorsal recumbency. We have to flip them, put them in lateral recumbency. And there is clearly, you can, I'm sure you all can imagine, the height of like the shoulders and the neck, so if you just put them in lateral recumbency, there's no way we're going to get any diagnostic imaging. So we have to use a lot of padding and adjustment, and it takes some time to get used to that, definitely. But once you play with it a little bit, you get how it works. But basically, we use some pegs, and it's hard, might be hard for you to see, but there's one under the mandible here, two kind of like on the more like end of thoracic spine, one called the cervical spine, and it's quite nice how this shows the changes affecting both like the vertebral canal and the spinal cord. Let's look at this kind of neutral, and being like we did this in both disc and osseous-associated CSM. In the osseous-associated CSM, in the disc-associated CSM, we did traction too, primarily because of historic importance for that. But let's focus on this here. So this neutral position, two areas of spinal cord hyperintensity there, both 5-6 and 6-7. What happens when we flex the neck of this dog? Well, you can see that the area of hyperintensity shifts cranially quite significantly. It's not at the disc level anymore. But what is quite dramatic is to see this compared with extension. Look at the severity of the compressions at 5-6 and 6-7, and compare that with what we see at neutral. And most importantly, let's not forget, this extension here, I am just trying to mimic this. So what this dog actually has going on most of his day is this. Obviously, when he lowers his head and it's level with the thoracic spine, will be something like this. If he lowers it even more, flex it, we're going to see this. But you can imagine that all like this kind of, and in humans they call this pincer mechanism, kind of this multiple dynamic compressions happening God knows how many times during the day, right? Hundreds of times. How this can lead to a very severe spinal cord injury. And that's why when you look at this here, you don't see quite severe spinal cord compression, but then, I mean, you see how there's a marked hyperintensity within that spinal cord. Well, looking in extension, it's very clear why that hyperintensity should be there, right? So, and the same thing, we saw marked changes in osseous-associated CSM, and we saw things that, I didn't expect. For example, neutral position, you see this kind of area of hyperintensity kind of in the dorsolateral aspect of the spinal cord. I honestly would just I'm sure I would have just ignored that. I don't see anything that's relevant there. Well, when I put the dog in extension, look at what that was. That's a big, big extradural synovial cyst. Quite important that not when the dog is, again, level like thoracic and cervical spine. When the dog like lifts his head up and is an extension, we can see how that cyst becomes quite compressive. So I would say that MRI is definitely the best way to diagnose CSM. But if you really want to understand exactly what's happening with the cervical spine of your patient, you've got to do extension MRI. You've got to do dynamic. I wouldn't even say views, because it is kind of time consuming to do this. And if you have to pick one, just go with extension. That's what I do here. Okay, depending on the situation, I would add flexion, but it depends on the situation, depends on anesthesia, depends on age, depends on a lot of things. But extension, that's now standard for all MRIs of like CSM cases or cases that could potentially be CSM affected. Okay, and I would also add this related to MRI, which is, again, the disease is focused on the caudal cervical spine, 5-6 to 6-7. But we do know that these many dogs, primarily the younger ones, they have multi-level compression, and throughout the cervical spine, and you can see in areas sometimes are really, really far cranial. And why do this is a great example, another German Shepherd. And this is an MRI that wasn't done here. The dog came from another place here in the US for a second opinion. He had disc compression. He had lumbosacral disease, had a bunch of other things happening. And we decided to magically manage the dog and see what was happening. And when we did the follow-up MRI, we see that, okay, we saw that the lesion remains there, maybe better, maybe worse. I mean, you can see that there's a difference in imaging quality. This was, I think, a 1 Tesla. This is obviously 3 Tesla. But the key thing that's very important is this dog had a very, very severe compression between C1 and C2. Then you can say, well, that is not really reported, and I agree. I don't think it's very well characterized at all. But we see it. It's not a big component of the disease, but we see dorsal compressions at C1, C2. Occasionally we do. The same way that we can also see compressions in the craniothoracic spine. Okay, so T1, T2, T2, T3. And usually those we see more in like giant breed dogs, but can we see that in a large breed dog? We can. So I would say if you're going to do like imaging for these cases, just really try as hard as you can to go from C1 to T2, then you get a picture of everything that's happening. Related to that, I really would strongly suggest that you consider adding extension views, which the extension, as I put here, I think is actually the normal view. It's the way that this dog walks around. I think that's kind of would be the physiologic view. It's not necessarily easy, but it can be done in low field MRIs. I know because, as Simon alluded initially, I just came back from Brazil and I teach courses there, and I have a low field MRI, and we've done like extension views there without any problem. So you can do, I would say, with any kind of MRI. Brief summary. I guess you already got that it's not a very simple disease. There is, from like a basic pathogenesis, static and dynamic component, both play a significant role and both act together. And there's like a bunch of molecular mechanisms that add to those. And I would say key point in terms of imaging, we need to remember of extension, kinematic or dynamic MRI. Simon, if you allow me, I just want to finish with this because I guess the neurology community worldwide is still devastated with the loss of Dr. De La Renta. I guess we can probably say we're all, to some extent, his child, and he was father for all of us. I think back in the 70s, he published also a paper on, basically he published on everything, but he published with Dr. Trotter a paper on cervical spondylomyelopathy. So I just feel honored and blessed to have had the opportunity to learn, to work with him, and to have him here in Ohio. I guess one of his last appearances as a speaker, like at the conclusion of the brain camp here, and this is like a gathering of that day on Friday. So thank you for having me and the opportunity to share this, and I want to say thank you, Dr. De La Renta, for everything you've done. Okay, so with this, I am very open for questions. Thank you so much for having me.
Yeah,
thank you very much.
Yeah,
go ahead, Simon.
Sorry. Yeah, no, thank you, Ronaldo, for that, and a fitting end and tribute to Dr. Hunter, who, as you say, we all owe a great deal to, and will never be replaced, obviously. But thank you very much for your presentation today. I think Laurent has some questions maybe for you.
There's a few questions on the comment box. I think there is. I'm going to put the question on the screen, Ronaldo, and you can read them. I think that
can I stop sharing here, like Laura? Can I stop sharing and see you?
Yeah, absolutely. Yeah.
Okay, all right. Now I see you. Okay,
so hopefully you'll be able to read the question. But that go a little bit with, one of the questions I wanted to ask you is, obviously, CSM is a mixture of static and dynamic compression. Totally understand. You remove the dynamic compression, the dog improve. But will you be in favor of not using motion sparing technique, of using or do you prefer, if you have to treat them, to stop the dynamic component or to keep the movement in this case? And that go a little bit along with the question that is put there, which we can do after that.
Yeah. Great question. And thank you, Gilberto, for the question. So I don't have experience with this Silox cage. I've heard of it. I think there's a paper on it, I believe. I didn't go into surgery, but there are more than 35 different techniques that we can use to treat this disease. Again, along the same lines of 15 names, why do you need 35 different techniques to treat it? Well, clearly not a single one stands out as being superior. I had, and I'm just going to say that, a lot of faith in the disc replacement technique, like motion sparing, I guess, as you alluded to, Laurent, because in humans that seems like I participated in, and I tried to go, but 10 years ago or so, I went to, there's a very, very nice meeting called Cervical Spine Research Society here in the United States. Amazing meeting, super high level. And I attended that meeting, and clearly, the most favorite technique at that meeting, that's about 10 years ago, was disc arthroplasty or disc replacement. Many different, there were, I think back then they had 7 different types of discs that they were using, hundreds of cases all over. They were still using fusion quite a bit. But that clearly seemed to be the direction that they were going to in humans. And about that time is when Filippo Adamo came out with his disc, and we started using here right away. Unfortunately, and my thought was, okay, so when we decompress, we may or may not see fusion. When we fuse, we know that long term is, if we really don't fuse the body, the likelihood of failing is very high. So what if we just try to preserve the motion and kind of keep things as they are? And then comes Adam with his disc, biomechanically studied and everything. And so we started using it, about 10 years ago. I can't say that it really does what the idea is, motion preserving. I don't think it is. I think it might be for, a few months, but in the long run, after 6 months to a year, I think it completely loses the ability to actually act as an artificial disc. And so no difference in the outcome long term. You see dogs that do very well, you see dogs that don't do as well. I mean, you see what we've seen with any other technique. So no difference.
There was a question about more the MRI, which was another question I wanted to ask you. You showed the device that you use for extension and flexion, but I presume that device limits a lot the type of coil you can use. It can only fit with a body coil, and not every MRI has a body coil, especially low field don't have body coil. So how do you overcome that? And the question that was put by Ronan was, do you do this MRI in lateral recurrency, and how do you achieve extension if you can't use a body coil, which is the case with most MRI?
Well,
a lot of MRI.
We in Sao Paulo, we've done extension with the low field MRIs, like the SROT ones, like 0.227 Tesla. And basically, we just put them in lateral recurrency, use sandbags or something to just keep the extension, but not controlling specifically angles and anything. We just kind of extended the neck, and honestly, hard to maintain that in that position because you don't have any secure way to keep them that. But I can try to see if I find it quickly, but what was clear to me is that even significantly less, like fewer degrees of extension compared to what I do here. So maybe half of the extension I achieve with the Wobblinator is already enough to highlight the dorsal component and the ventral component and the pincer effect. Again, this is done low field, and I know it's possible. I can't remember the coil we end up using for that, but I know we got diagnostic images in a 0.27 MRI. But it has to be done lateral recurrency. I mean, again, let me rephrase that. Can we do that in dorsal recumbency? I guess we can. I haven't tried, but if you basically try to put something, like, for example, when I'm approaching the caudal cervical spine, I like to really open it up as much as I can. So what do? I put a lot of padding right around like the cervical thoracic junction, and rather than keeping it like here, I open it up. Could we still try to get an extension view in the dog in dorsal recumbency? Maybe. The problem is obviously like the cervical spine, the caudal cervical spine will be farther away from the coil. And if we're talking about a surface coil, so, and maybe the bulk of the volume wouldn't allow that. But maybe there would be a way to do this in dorsal recumbency. I haven't tried. I've tried both high and low field and lateral recumbency, and I can tell you that it works.
Good. I think there's one last question. Hi, Ronaldo. We often diagnose CSM through CT. Would you advise to do dynamic studies, i.e. flexion extension with this modality?
Great question, Michelle. You can try. To be honest, I don't. The problem is here, okay? And we've done studies comparing CT and MRI, and CT is great to look at bone, but when you're talking about soft tissue components, meaning like longitudinal ligament, like ligamentum flavum, disc protrusion, it's like, non-contrast CT is not ideal. If we were to add and do CT myelography, which then you highlight exactly everything we've shown on MRI, the issue with that is that when you go back to the 80s and you see the dynamic studies done with myelography, you'd see that a very, very high percentage of dogs worsen significantly after myelography. I must emphasize this, no one asked me, but after then, I don't even know how many, but at least 50, maybe 100 kinematic MRIs. I have never seen a single dog worsen after kinematic studies, which seem to happen in 100% of dogs after myelography. So I think the dynamic component with a CT myelography and the chemical meningitis induced by the contrast would be probably significantly less than ideal. You don't want to have a down dog after an imaging study like a 70-kilo dog. So I don't know if that would go very well with CT, and I'll be very cautious about it. I have never done, and not if I want to.
I think there's a bonus question, but more for me. If you have to do traction view, what will be the degree of traction you try to achieve, and what is the basis for that? You know that there is only one vet rad, paper, if you could say, from Jacques, that give a number, but there may not be any basis for that. So
there actually we published on that too. But it was mixed up with so many other things that no one knows that. But if you look at a paper where we compared CT and myelography, that we also published in 2006, we discussed quite a bit how to do it and forces and all of that. Generally speaking, that's a lot of from interstitial spinal cord pressure studies in humans. We shouldn't use anything more than probably safely more than 20% of the dog's weight. So 40-kilo Doberman, not more than 8 kilos. If you do that, and I've done that, I've done that in dozens and dozens of cases, have never seen anything. I think above 25%, I would say that you start to going into a dangerous area. We can do that. I've done plenty of like distraction studies here. After I've learned everything we can see with the kinematic, the extension views, I honestly kind of sort of moved away from traction. I don't think they're what I thought that I don't think they provide as much information. And to be honest, you can, with 20-25% of the dog's weight, you can make any lesion, no matter what they are, dynamic or traction responsive to some extent. Again, like we have a paper from like 2006 that we showed how we had 3 raters and how it was very inconsistent. Basically, the agreement was just about 33%. based on whether the lesion was dynamic, static, or static for a dynamic component. So we're all over the place.
Yeah, no, absolutely. And the other issue is obviously when you do surgery, if you really distract to that extent, a lot of the implant you will put will fail. And I think for any one of us that have done distraction fusion technique, you try to stay away from over distracting, because that's where actually you got a lot of failure. So putting that amount of distraction, maybe on MRI, it resolves the lesion, but at surgery, it's often lead to failure of the implant, for sure. There's no other question. Thank you so much for taking the time for, explaining all your experience with CSM. I said jokingly that you got as many paper on CSM, but someone had complication treating them surgically, which I think is probably an understatement.
And we're back. I was trying to mute you because I knew that was something like that was.
A very mean statement. So thank you guys for considering me, for having me here. I truly feel honored to have this opportunity to share a little bit of what we do, and I hope you both and everyone else who are and will be watching as we enjoy it too.
Yeah, thank you very much.
Someone, you got the last word.
Yeah, no. Thank you very much, Ronaldo. I really appreciate it, and I'm sure everyone tuning in has learned a lot from your experience and the work that you've done in this arena. Great. Thanks everybody for tuning in now, and spread the word that this will be available on the site for those that weren't able to get to it. Thanks very much to Hallmark Advanced Veterinary Imaging for sponsoring this session. Join us in a couple of weeks when we'll be back with another imaging spinal imaging session, and we'll see you then. Thanks very much.
Take care,
Bye-bye.
guys. Bye-bye.